So perhaps I'll just focus my comments on the advanced stage classical Hodgkin lymphoma, how we treat them frontline in 2024. Well, I mean, currently we still, in England at least, we still have the choices of an ABVD approach or an escalated BEACOPDac approach. I think more and more people are using escalated BEACOPDac because it definitely does cure more people than ABVD. And I think with the modern approaches of using 2 cycles, interim PET, and if that interim PET's negative, then only 2 more, then actually the toxicity, particularly in the longer term, seems to be really quite modest. So I think more and more people are using escalated BEACOPDac. What we would like to be able to use, we'd like to be able to offer a more targeted approach, so using AVD Brentuximab, which is licensed for stage 4 but not reimbursed. However, we may see that going back through NICE, so we may have access to that. And sticking with the Brentuximab theme, we also have the HD21 trial showing a very impressive readout for BRCAD, so incorporating Brentuximab into an escalated BEACOP type approach. However, that needs to go through the reimbursement procedures before we can use that. The really hot topic though at the moment is the SWOG 1836 trial, which compared AVD Brentuximab with AVD Nivolumab, and there was a significant improvement in 1-year PFS, so very early data, but a reduced toxicity profile for the Nivolumab AVD. Now again, that's not licensed. I don't know if it's ever going to be NICE approved, but it would be it's very intriguing data, particularly for older patients, and I would love to be able to access that at some point. Now, of course, relapse really depends on what you've been given first line. So one of the really hot debates at the moment in 2024, I mean, at the moment we use second line combination chemotherapy and try and get them to autograft. That's still the standard. And then we have PD-1 inhibitors and Brentuximab third line plus. However, if we've used a checkpoint inhibitor or indeed Brentuximab first line, how is that going to change the sequence of our relapse chemos? And it's too early to tell really. I think if we're using Brentuximab frontline, we'll be relying on checkpoint inhibitors more, and if we've used checkpoint inhibitors frontline, we'll be using or relying on Brentuximab more. So I guess it's watch this space, but it's an evolving pathway.